Hey y'all, and welcome to another episode of Hey Dr. J, where we cover pharmacy basics one topic at a time. As usual, please like the video and make sure you subscribe to the channel. If you have any feedback or questions, you can post them in the comments below, and we still have the Google form available on the channel page itself. Alright guys, and today we are going to start a new topic. So today we are discussing hyperlipidemia, which is high cholesterol. So first of all, what is cholesterol? It's a fatty light substance that can be found within your cells. It's typically made within your liver and is used to help repair damaged tissue within your body. So your body does need it in order to work properly, but it doesn't need a ton. And with the typical American diet and a non-active lifestyle, we tend to take on too much cholesterol, which of course will store in our fat in our body, so on and so forth. It'll start to clog your arteries, which leads to problems such as high cholesterol and coronary artery disease, which is the hardening of your arteries, as the cholesterol will actually start to block the pathway, making it more difficult for your blood to flow in your body, leading to a number of other problems, which we can discuss at a later time on another day. So with cholesterol, you have four main types. You have your good cholesterol, which is your HDL. You have your bad cholesterol, which is your LDL. You have your non-HDL, which is like your VLDL. And then you have your triglycerides. These are the main four that you will see as a patient. There are a couple of extras, but in all honesty, cholesterol is a very bulky topic and tends to be kind of dry. So I want to approach this in a way that a patient would per se. So I'm not covering every little thing, every little basis when it comes to cholesterol. Now, if you really want me to cover cholesterol top to bottom, like what is HDL, why is the range of this to this, and blah, 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 I need y'all to like this video and drop it in the comments below, and I will make an additional video explaining everything from top to bottom. There's a lot of information out there on cholesterol that you can find for yourself on websites such as the American College of Cardiology. Of course, I'll drop that link in the video description below, alongside the other references that will be used in this video. The 2013 guidelines leans heavily on something called the ASCVD calculator. Lord be with me. The atherosclerotic cardiovascular risk calculator. That is the only time I'm saying that in this video. We will never use it again because as a patient, you will not need that information. Plus, the guidelines were updated in 2018 and a lot of this information was kind of filtered in by default. So long story short, we are aiming for a heart healthy lifestyle across the board in order to reduce your risk for ASCVD. So cholesterol can get overwhelming because there's a bunch of abbreviations and criteria involved. With diabetes, you go here. With age, you might go over here. If you don't have this, but you are associated with this, they may categorize you over here. Just hold on to the fact that your best method is determined by your overall health and the information that you share with your provider. So please be honest with everything that's going on with you health-wise so that you and your provider can start on this journey with the right foot. Lifestyle modifications is next, and managing cholesterol does involve diet. You are not going to be able to get away with this no matter what you try to do. So healthy dietary intake focuses a lot on your vegetables, your fruits, your whole grains, legumes, healthy protein sources such as low-fat dairy products, low-fat poultry, fish and seafood, nuts if you're not allergic, and limited amounts of sweets and sugars. Now notice that it doesn't say you have to completely cut these out, it just says to do them in moderation. You do have dietary options such as the DASH method, which we have covered in another video. Make sure you go back and watch that one, which does help with both cholesterol and your high blood pressure issues. The main difference in this case would be you would lean more so on fat-free products than just low fat. But as a patient, you do have the option to go one way or the other depending on where you stand. So just keep that in mind. So let's get into the meds. The first class is the most common class that you'll see for cholesterol, which are the statins. So you have atorvastatin, rosuvastatin, which is Crestor, simvastatin, which is Zocor, and pravastatin. Of course, there are others, but I'm just listing some of the ones that you will typically see in a retail or community setting. The doses can range from 10 to 80 milligrams, and these are categorized mostly by intensity. And when we are talking about intensity, we are mostly discussing how aggressively it is trying to lower the amount of lipids in your body. The class overall is considered well tolerated, which I used to find ironic in my scope of practice due to the sheer amount of patients that used to complain about these statins because of their side effects. But the good news about the side effects is most of the time they do go away, and I would just encourage them to give the medication time to work before they decided they hated it forever. Now, the downside is that time frame could be as low as 3 weeks or as long as 3 months. It just kind of was a give or take, and it does kind of depend on the makeup of your body and what's actually going on. So, what are these side effects that are in question? The biggest side effect is something called subjective myalgia, which is muscle pain. This pain can be a bit random on location and seems to happen more in women, people with low BMI, people with high physical activity, people with Asian ancestry, and excessive drinkers. It can happen between 5 and 20% of the patient population, which does seem to make it more common in my opinion, and does lead to more non-adherence, which I've seen in practice. Because when a patient doesn't feel well, especially if it's causing them pain, and pain of course is subjective to how bad the patient feels, they're not going to want to stay on this no matter what you tell them or how much you encourage them. Now, there are other side effects, but most of these are fairly rare. And when we say fairly rare in the medical terms, we're talking like 1% or less. So these would include liver failure, memory loss, myopathy, which is a disorder of skeletal muscles, and like dealing with the function of how well or how poorly you can control those. You can't write them off as completely impossible, but taking these meds and having these happen directly because of the meds is fairly unlikely, or at least in the case of unfortunate series of events. Interactions. So statins are big for interacting a lot with alcohol, which can increase side effects, and grapefruit juice. This was a big one in pharmacy school because of the CYP inhibitor chart. Grapefruit, again, which I know I've mentioned in another video, is a big inhibitor that likes to basically grab drugs and render them basically useless. So if you are a person that loves grapefruit juice and tends to need medication, try to separate them by a minimum of 2 hours before you do anything else, just to make sure that the medication can be absorbed and get to the places it needs to be, and do the things it needs to do before it's flushed out of your system. And of course, when we're talking about inhibitors or anything that can bind to the medication, if it's binding to the medication or not allowing your body to get rid of it, it's going to increase that risk of side effects, which is in turn going to make that muscle pain even more noticeable, which in turn is going to make the patient not going to want to take this. So try to keep all of that in mind when you are talking with your doctor about these things. As for the alcohol, it's not saying that you necessarily have to stop drinking, but just drink in moderation. Please drink in moderation when you can, and please don't use an actual alcoholic drink to take the medication. Listen, I am not judging. I am just covering my bases as a medical professional and instructing you to do things that I have actually had questions about in practice. If you're on any heart medications like amiodarone, HIV medications like Norvir, or immunosuppressant medications like cyclosporin, that one always gets me. Sorry about that. Always separate them by your statins by at least an hour for this similar reason as the grapefruit. They are either inhibitors or they will metabolize the drug, so either make it run out faster or it'll bind to the drug. So just try to give it a little more time in these cases as well. So what I've personally seen in practice when it comes to patient and cholesterol medications, not just with the statins, but cholesterol medications in general, is they don't stick with it because cholesterol is not necessarily something you can tell gets better quickly, nor something that you can tell like physically. Like with blood pressure, as it gets better, your body kind of feels better. Your life just kind of seems to kind of pick up and go. But cholesterol is not necessarily something you can feel. And when it comes to your labs, like it takes roughly 3 months before you can see a physical change. You add the possibility of muscle pain. Some of these medications are not covered due to insurance reasons. And then patients are like, count me out. I'm good, bro. I'll take my chances. I like bacon and eggs anyway. Blah, 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 blah. I'll see y'all on the other side. Meet you at the crossroads. The good news is when it comes to statins, even if you fail like a therapy, let's say you take a atorvastatin and it doesn't work. You have some issues, the muscle pain gets too great, you quit. Statins allow quick resets. Like it's something you can try again and again unless it is a serious case. And what I mean by that is you can take a brief break, try to figure out where the muscle pain is actually coming from, because sometimes it'll just notify if something else is going on. Like if you're having a joint pain of some sort elsewhere, then you get off the statin, narrow down where it's actually coming from, get back to it, or switch to a different statin, because even though they're all in the same class and they all work the same, if one doesn't work for you, that doesn't mean that all of them are not going to work for you. So the statin class has quite a bit of versatility and does give patients a chance to try again and again as needed. Some other therapies when it comes to helping with that muscle pain, if it is something that's going on longer than 2 or 3 weeks, is making sure you're not overdoing it when you're exercising, because exercise is literally tearing of the muscle in order to build it back up to make it better. They will ask you to do like kind of lightweight training at first, and they may also ask you to take coenzyme Q10, which is also known as CoQ10. You may have heard of that in a couple of places or seen it. You can take that alongside your statins as long as you check with your doctor first, because especially if you're taking it over the counter, no two CoQ10s are equal, and you want to make sure you are not setting yourself up for an unintentional interaction, or you don't want to overdo it and end up with another problem. So as always, make sure you talk with your provider. All right, guys, for this one, I think I am going to cut this here. Like I said, cholesterol is a bulky topic, and I don't want to bore you guys too much in one go. So we're going to stop here. As I said before, make sure you post any feedback or questions in the comments below. You also still have the Google form that's available on the website itself. And until I see you guys next time, stay safe.